I have the privilege to introduce the next speaker, Dr. Kristen Arredondo. She trained at Baylor College of Medicine for medical school and then at UT Southwestern for residency and fellowship, and then was previously at Nationwide Children's where we overlapped. So I was a fellow at the time and she was an attending, and so I got to learn from her then, and now we get to work as colleagues, which is awesome. She is an expert in infantile spasms, drug-resistant epilepsy, the surgical management of epilepsy, and tuberous sclerosis. So she's going to focus on this talk on infantile spasms, but very lucky to have her.
All right. Well, thanks, you guys. Again, Kristen Arredondo. I'm here today to talk about infantile spasms and recognizing this neurological emergency, one of our emergency seizure types in epilepsy. And I do have a couple videos to show, and the whole point, of course, is to be helpful to you. So please pause me if you would like to say, like, oh, can we watch that video again or anything like that, okay? Because that's the whole point of this talk. All righty, I have no disclosures. So my objectives today are for us to recognize when to suspect infantile spasms, who are the key populations that may have it, what do the spasms themselves look like, and to tell you a little bit more about the diagnostics and treatment options so that you can help guide families on what to expect and support families through the common issues that may arise. So I've got this first video here. And so it's the video overlaid on the EEG in the background. Let's see. All right, there's one. There's another one. And I think when I recorded this, the sound doesn't come through very well, but she cries every time. So there's another one. So very stereotyped, right? Each time she's raising her arms, she's doing a little belly crunch, and her hips raise up, her neck moves a bit, and she gets upset. And they're at a very regular interval. You can anticipate when the next one's coming. They look the same each time in this cluster. So some of the classic features of a child having spasms. This is another child having slightly more subtle spasms. You'll see two in this video. Watch her face closely. That was one. And then this second one. That was it. So this one I'm going to play again because it's kind of subtle. But you can appreciate that this baby, so she kind of does a little neck flexion and she does what we call the retch sign, like kind of contracts her lower lip during the spasm. And sometimes children will just have a little. All right, there's one. And here's her second one. So just that little subtle shoulder movement, lip contraction, little retch sign there. So pretty subtle, but it happens in a cluster. So every single time she's doing the same thing, and she becomes upset as it happens. So as far as talking about the description of what these look like, so they can involve different types of movements, but most commonly they are classified as flexor spasms, or extensor spasms, meaning either they're crunching in, arms in, neck flexing, abdominal crunch, or extending out. Arms suddenly extend, head back, eyes may roll up. And sometimes they are more subtle, like that little retch sign, the little lower lip contracts, and they may just do an eye roll, and that's it. Classic context, though, is after waking from sleep. So they've had their night's rest or they've had their nap, and within several minutes of waking up, they have this clustered for several minutes typically. And again, stereotyped, and you can anticipate the next one. If a family is not able to catch a video of it, my suspicion for spasms tends to go down, because usually that cluster is long enough. They may not catch the first one, but they'll catch the next ones, right? Because you know it's going to continue going. West syndrome. So sometimes we'll see in the chart that kids ended up getting a diagnosis of West syndrome. We sometimes don't use that term anymore, but it just kind of depends on which patient may fit the features. And so that is a triad, a clinical triad of a patient who has spasms, who has a classic EEG finding of hips arrhythmia, and who has demonstrated some stagnation in their development or regression with some loss of skills. As far as who gets spasms, so it actually affects 1 in 2,000 infants, so not entirely super uncommon, especially within our center here where we're seeing lots of these babies. Typical age of onset is 6 months, but usually within a window of 4 to 8 months for most infants. There are certain populations we know are at higher risk for developing spasms, including kids who have tuberous sclerosis, kids with trisomy 21, and kids with history of prematurity, especially with any sort of abnormalities on the brain MRI or history of having neonatal seizures while they were in the NICU are all at higher risk. And speaking to neonatal seizures, there's a really robust neonatal seizure registry that looked at outcomes for kids who have had seizures in the NICU. This is a multi-center cohort study. And of all children who had acute symptomatic seizures in the neonatal period, meaning seizures due to like a perinatal stroke or hypoxic ischemic encephalopathy, those type of things, 6% of all of them will have a chance of developing spasms. But most telling is the children with the 3 risk factors listed here, it's higher than 50% chance of developing spasms. And that's if the EEG was severely abnormal, if they have evidence of a deep gray matter or brainstem injury on the MRI, or if their tone is abnormal at the time of their discharge from the NICU. Those children, if they have all 3, greater than 50% chance of developing spasms, so being on high alert. And it should be part of what we're talking with families about when they leave the NICU is being aware and looking out for these type of movements. Developmental stagnation or regression. So this is part of course, the screening that all pediatricians are doing, right? Looking for any signs that a child is no longer making progress on the trajectory that we expect for them. Or if they've lost skills, certainly if they've regressed, that's very worrisome for any sort of a new cognitive dysfunction. And many of the epileptic encephalopathies, including spasms, might be a reason why that could happen. We consider these a neurological emergency, so spasms are one that we want to really aggressively figure out and diagnose right away so that we can start treatment immediately. The goal being that we want to prevent children from having any of the neurocognitive damaging outcomes that can go on when spasms are left untreated. And so we recommend that these patients get sent to the ER from clinic. Sorry, this I think is a little bit different than my original slide, but also another option is we have our same-day neurology phone line so that we can get a same-day appointment and EEG for these patients. If you're suspecting them, you're seeing them clinic right then, please call us and we can also help try to expedite that so that we can have one of our board-certified neurologists see these patients in clinic after a same-day EEG and get the ball rolling. Sometimes the kids end up needing to be admitted to the hospital overnight anyway, say if we weren't able to capture the event or get enough clarity from the short EEG, or if we need to expedite getting their workup inpatient, but we can get families that contact quickly. In terms of diagnostic workup, so when patients are suspected of having spasms, they're all going to have an EEG, typically done as overnight long-term video EEG monitoring within the hospital to really clarify the diagnosis. A patient who is diagnosed with spasms is going to have a follow-up EEG in 2 weeks. Usually we prefer to do that overnight in the epilepsy monitoring unit. We're really just looking for spasms remission, like did we adequately treat it or not? And we use the 2-week mark so that we can quickly shift therapies if we need to in case the kids are refractory. All the children will get an MRI of the brain if they've not had one before. And then commonly we'll do genetic testing and may consider metabolic testing, especially if we don't find an abnormality on the MRI that would tell us why they're predisposed to spasms. This is our spasms protocol for adult children as far as looking at the diagnosis. So first off, you can see at the very top is the EEG to capture the spells and to make sure to get sleep. Sometimes we see those abnormalities come out even more during the sleep state on EEG, and that can really help us clarify whether the child has hypsarrhythmia or abnormal EEG pattern that would go along with having spasms. And you can see here on the right, if they don't have spasms or hypsarrhythmia, but we're still suspicious of something, seizure or otherwise, we'll have them come back to the clinic in a week and may even repeat a long-term EEG. If they do have spasms or the EEG abnormality of hypsarrhythmia, they're going to get an MRI. If they already have a known etiology, we may not need to repeat it if we know that they have, say, a severe hypoxic ischemic injury or something like that. If they have no known etiology, they will definitely get an MRI, which we do as our epilepsy protocol with specific sequences obtained here. And then if we don't find anything on the MRI that would explain their risk for the spasms, then they will certainly will get an epilepsy gene panel. And then we may do also some metabolic testing and send some kind of first level metabolic labs at that time while we're waiting for those results to come back. As far as etiologies, the vast majority of kids will have some sort of a structural or genetic contribution that would explain their spasms. So structural, most common ones are things like having perinatal stroke or hypoxic ischemic injury or periventricular leukomalacia related to their prematurity. There can be other congenital brain malformations due to a lot of different types of things, but things like focal cortical dysplasia or the tubers that we might see in tuberous sclerosis or other differences in neuronal migration and things like lissencephaly. Some children with torch infections, so things like congenital CMV, is super high risk for spasms as well. Any child who's had a history of neonatal encephalitis or meningitis is also at higher risk. And then there are kids with other chromosomal abnormalities that would predispose them. Like children with trisomy 21 have spasms at a greater rate than children without. They tend to actually be very responsive to treatment, so trisomy 21 portends a pretty good outlook in terms of spasms management, but certainly are at higher risk. People with TSC, tuberous sclerosis complex, definitely is something that we're always looking out for. And Dr. Roach had already referenced the fact that we have some data on even preemptively monitoring children with TSC with EEGs every 6 weeks for the first year of life in order to identify abnormalities before a child develops spasms or other seizure types. There are other monogenic disorders that can predispose children to spasms as listed here, as well as some metabolic disorders that you can see here too, like urine disease and pyridoxine-dependent epilepsy and pyruvate dehydrogenase complex deficiency, glutamate transporter 1 deficiency, so lots of other metabolic disorders that we don't want to miss out on since those have very specific treatments as well. What I kind of thrown around the term hypsarrhythmia a few times, but I wanted to clarify what I mean by that. So hypsarrhythmia is just describing the most classic EEG pattern seen in children with spasms. It describes a background EEG activity that's high in amplitude, that's chaotic and disorganized, and that's interrupted quite frequently by spikes or epileptiform activity that tells us about that very high risk of seizures. And then there's a very specific correlate to what the EEG should look like during a spasm itself as well. We used to more clearly categorize people as whether they had hypsarrhythmia or not, or there's like a modified hypsarrhythmia term as well. There's been some movement over the last few years to instead use a based scoring system. A lot of us have started integrating that into our EEG reports, if you see that. And so the based scoring system is just describing EEG abnormalities and how significant they are in the context of known spasms. So the kid is confirmed to have spasms, but what's their background? And so we're comparing kids as in terms of not only at the time of diagnosis, but to establish remission afterward. Like we want to see their score have changed significantly. So like a score of 0 is a totally normal EEG. A score of 5 is definite epileptic encephalopathy, and that just means they have certain features like the background amplitudes and a significant number of spikes and the like. And this scoring system has been shown to have much better inter-rater reliability compared to hypsarrhythmia, where different epileptologists may interpret that in different ways. And the goal of using the base score, again, is that biomarker to assess for spasms remission. So the kid's no longer clinically having spasms, but have we treated the brain adequately so that they're not having all the cognitive impact of having the chaotic electrical pattern in the brain. So here's just a sample EEG just showing all these very active spikes on here and some abnormalities in the background amplitudes. You can still see some sleep things, so just demonstrating some of this abnormal activity. One question that certainly comes up a lot is, can the EEG ever be normal in spasms? And that is extremely unlikely, is the main thing, the main takeaway I would want to say. There's only been one factor that's been found to be statistically significant in terms of whether or not a child will have classic hypsarrhythmia when they have spasms, and that is very young age of onset. So kids who start prior to 3 months, which tends to be kids with either very significant structural injury to their brain or certain genetic disorders. But their EEGs, to be clear, are not normal. They're abnormal as well. So children with spasms should have a base score, again referring to that abnormal scoring of the EEG, of between 3 and 5. So it's abnormal regardless, even if it doesn't meet the classic hypsarrhythmia. well, so especially if you have a child who's like right in that prime time age, a 6-month-old who's doing a weird movement, if they have a completely normal EEG, it's probably not spasms, even if we don't capture the event itself. There are certainly tons of mimics to spasms, which makes it so tricky, because as everyone in this room knows, that children are doing all sorts of weird movements. And that's why we love the videos as well. I know that Dr. Clark had just referenced using that video program, but it can be so, so helpful to see what families are seeing at home. One of the biggest ones, of course, is reflux, or what we end up giving the eponym of Sandifer syndrome when they're coming in because they're doing these repetitive movements from, being laid down. They have reflux, they're uncomfortable, they crunch, and it can happen. And then they scream, right, because they're uncomfortable, and so it can have that same repetitive fashion. Some children who just have a hyperactive Moro reflex or startle, especially when we're worried about it in really young kids, that sometimes might be the contributor. Shuddering attacks, which is just a benign movement that can be stereotyped and can be worrisome sometimes as well. And then there can be other movement abnormalities like benign myoclonus or spasmus nutans that are just other diagnoses we might make on the basis of what the kid does during it. Again, why the video is so helpful. And other epilepsies, of course, are in the differential too, right? There's lots of different types of epilepsies that may look like spasms, but may be managed in a little bit different way. For treating spasms, so this is just some pictures of a few of our treatments that we're using. So one is ACTH, Acthar gel, which is an intramuscular injection. One is vigabatrin, which is a powder packet. And then, of course, prednisolone are most commonly used, right? Most readily available and cheapest option. So we've got our treatment protocol here. This is our Dell Children's Spasms treatment protocol. So in kids who have unknown etiology for their spasms, we've confirmed they have spasms, but we don't know why. They have not TS. So the standard is to start prednisolone, so high-dose steroids, and we're talking 8 mg per kg per day divided TID, and we do that for 14 days. And when they're leaving the hospital, they should get the whole 2-week high dose plus the 3-week taper as one single prescription. We don't want families to accidentally just stay on that high dose forever in case we lose them to follow up. And then they're going to come back in 2 weeks, and they're going to get repeat EEG, whether that be a prolonged one in the clinic setting or overnight in our epilepsy monitoring unit, and decide have their spasms gone into remission or not. Of course, if the family's saying we still see them, that's pretty easy. We know that we need to switch therapies and switch it quickly within that 2-week period. If they've resolved, they'll just complete the prednisone taper, and that's a single treatment course. They don't need to go on to another anti-seizure medicine unless we see that they're at risk for other seizure types for whatever other reason. If they have not resolved, what we typically go to next is vigabatrin. That's our most commonly used next line. And sometimes we may go directly to ACTH, but we'll talk about some of the caveats and considerations for which medication might happen next. One particular one we definitely want to talk about is TSC. So if the patient has known tuberous sclerosis, vigabatrin is the first choice and first line agent. We ramp it up pretty quickly to our goal dose of 150 mg per kg a day divided BID. And then we're going to do the same thing where we repeat an EEG in 2 weeks. And if they're still having spasms, that's when we'll switch them to a hormonal therapy like steroids or ACTH. And we will typically continue vigabatrin, usually for a course of at least 6 to 12 months. When thinking about some of the considerations, of course, you guys all know about the steroid considerations, but especially at the super high dose, we're talking about kids who are very irritable, typically, and have an appetite increase, are not sleeping well, may gain weight. And certainly, of course, we're warning families about that because can be a big difficulty for them going home on this treatment course. They may have transient increases in blood pressure, some even to the point that they need to temporarily be on a blood pressure medication, but that's not common by any means. They'll be immunosuppressed during that period, and we do talk about vaccines, and I'll bring that up in a little bit, and are at higher risk, of course, of gastritis and having transient hyperglycemia or adrenal insufficiency. I'll often ask families to see their pediatrician within a week just to do a blood pressure check and see how they're tolerating the medication in general. We used to always want to do some labs in between, like checking a urinalysis or a BMP, but it's not thought to really be necessary. We know that any abnormalities are going to be transient while they're on steroids. And then the main thing also I would say for the pediatricians in the room is please let us know if the families if they're still seeing spasms, especially if the family may not tell us, or you think they may be less reliable in telling us? Because we would love to switch therapies as soon as possible if we know they're still having spasms. We ask them when we meet them and first diagnosed with spasms to please check in with us in a week in clinic, or like by phone call or through the portal. If we're still seeing spasms, we're going to switch gears and start the prior auth process for the next medications. When we're thinking about some of these, so ACTH, that's the gel. It's given through IM injection. It's a hormonal therapy. It's been around the longest, particularly for spasms used since the 50s. It's refrigerated. It only comes through specialty pharmacy. It's insanely expensive. It's often a bit of a process with the prior auth. It does contain natural pork products, so being mindful of that for patients with religious exemptions. And it, of course, has the same side effect profile as prednisolone. We're using that same pathway, we're just targeting it higher in the pathway, right? But you're going through that same effect of really trying to just blast the brain out of this abnormal pattern that we've got going on. With hormone therapy and vaccines, we generally advise families that we recommend live vaccines not start until a month after their steroid course is completed, and any non-live vaccines can resume as soon as their treatment course is done. The next one is vigabatrin. So this is the powder packet, so you can get vigabatrin shipped to their home in powder packets. It works through selectively inhibiting the GABA transaminase that breaks down GABA in the synapses of the brain. GABA is a good inhibitory neurotransmitter, so we're trying to have some inhibition ongoing there. And specifically for kids with tuberous sclerosis, part of the way that it may be especially effective for them is by inhibiting that mTOR activation, which is a pathway that's gone awry in tuberous sclerosis. So it's, again, they get powder packets. It's reconstituted with water. So typically we'll say 1 packet per 10 mLs of water. It can be reconstituted at different concentrations, say if a child's on very limited intake of liquids or things like that, or can't tolerate that kind of volume. It is shipped from specialty pharmacy. Most commonly, we're talking about side effects of sedation, and another one I talk about, especially with kids who already have hypotonia, is the fact that it can worsen their tone during that time period. That can be something families really worry about, so I've found that warning them about it ahead of time can be really helpful. There is a REMS monitoring program, so they do have to sign and consent to be part of this program due to the risk of permanent peripheral vision loss. This was largely more seen in adult patients who were on it for different indications and for a lot longer duration of therapy, so exceedingly rare in infants who are on it for a shorter course of like 6 months or so. Like less than 5%, but that is part of the consent process, is talking about that, and we do recommend that the babies be seen by an ophthalmologist regularly to have a good fundoscopic exam. Vigabatrin also can be associated with MRI changes, so if you happen to get another MRI while they're on vigabatrin, you may see some signal changes in some various parts of the brain. It's reversible, and we're not really clear still on whether that means anything clinically for the patients. Prior auth, so as everybody here knows about doing all those, but so ACTH and vigabatrin both require prior authorization. They're both exceptionally expensive. They're both come from specialty pharmacies. They go to the home, so there has to be a family member who is able to coordinate with the specialty pharmacy for delivery. And then, of course, just thinking about ACTH in particular, another factor that may come into delay is ACTH program offers to have a nurse come to the home to train parents in how to do IM injections, which is awesome, but there can be like a little bit of time lag sometimes in getting that coordinated, especially for families who live further out. Of course, if we know that they're going to go on ACTH because they were just in the hospital and we're switching gears, our nurses bedside are fantastic about teaching families before they go about how to do IM injections, but that can be another delay. And then whenever we have kids come back into the EMU, things like that, we have another prior auth process for that. That one's pretty fast, but just thinking about there's potential for delays in here, and hence why starting with the steroids for many reasons. It's readily available. It's at everybody's pharmacy. We're not having the several days of delay that the potential of these medications may have. As far as outcomes data, which is usually what people are really interested in with spasm for sure, is one of the factors is spasms will go away in everybody at some point, usually by max age 3, age 4. But why we want to so aggressively treat it is that we know about the cognitive impact that this is having, and that the longer children are sitting there having this epileptic encephalopathy, meaning there's just chaos going on in the brain electrically, they're not able to learn and grow and develop at that same pace. So that's why we're treating it, really, is to get our cognition, give us the best outcomes for that. Children with spasms have higher rates of cognitive impairment. About 80% will have some degree of cognitive impairment, and autism is diagnosed in 20% of patients. The best outcomes are for kids who had prior normal development and who have a normal MRI and normal genetics. They're completely unknown etiology, otherwise healthy kids. They tend to have the best outcomes. Shorter time to treatment and faster time to stopping the spasms gives us those improved cognitive outcomes as well. About a third of kids will have spasms relapse and require switching to another treatment. Sometimes it's that you never got control in the first place and they're refractory and you have to switch meds. But sometimes they seem to be doing well for several months and then the spasms can come back. And we want to aggressively treat that second time as well. About 2/3 of kids will develop other seizure types. Sometimes it's focal seizures that are arising in one part of the brain, as Dr. Clark referenced. And in about a fifth of cases, it's developing Lennox-Gastaut syndrome, which is our very refractory epileptic encephalopathy, in which kids tend to have multiple seizure types that are very difficult to control and who have cognitive impairment and often some physical limitations as well. And between a fifth and a third of patients die in childhood. It's usually not because of their spasms directly, of course, but related to the underlying etiology, because those children who have the most difficult to control spasms tend to also have perhaps structural brain abnormalities or genetic conditions that might predispose them to this. In children whose spasms are refractory to the medications that we use, there's a lot of other options we have. Certainly kids who have like a malformation of cortical development and you know that eventually that abnormality needs to come out, say like a cortical dysplasia, or who have had a perinatal stroke and it's just affecting the one side and otherwise the rest of the tissue looks great. Moving relatively quickly to epilepsy surgery, even in young babies, can be super helpful in this regard and can cure the patient of their spasms and their epileptic encephalopathy. Keto diet is particularly helpful. Between 50 and 70% of kids will get remission with keto diet. It's certainly something we go to right away, especially if we're in the pipeline of going down the epilepsy surgery route. That's something we should always be considering. There are some other meds we can try. There was a lot of excitement about using topiramate for a while, things like that. It's kind of fallen out of favor, showing that it's not quite as helpful as anything else, but we may put them on other meds in the meantime while we're trying to get these under control and get them to a more definitive treatment. Some children get palliative surgeries, things like a corpus callosotomy to divide the main highway between the hemispheres. That can be helpful in stopping spasms and stopping some of the encephalopathy as well. Devices, a lot of families have read about devices and they'll come asking us, like, can we just put a VNS in for this or one of the other stimulatory devices in the brain or the vagus nerve, which have not been shown to have any indication for spasms as an isolated type. It may be helpful if they have other seizure types, but not for the spasms themselves. So my main takeaway is recommendations for new onset spasms. If you're worried about spasms, please call us, either call our same day line or send them straight to our children's ER so that we can admit them and kind of expedite this workup right away. And if it's not spasms, yay, fantastic. If the family might have been very freaked out for a little while because we want to expedite this workup and tell them to come to the ER or to come right away to a neurologist, but we would much rather have that than be missing spasms and letting kids sit out there for a while without us knowing what it is. All the spasms patients should be followed in our epilepsy clinic, and please let us know if you are encountering families who say that they haven't heard from us or there's been a gap in follow-up. Certainly not intentional. We want to make sure that we're not missing out on them, so please do let us know if anybody's not returning to neurology for their ongoing care. And thank you very much, you guys. Appreciate it. Right, and that's, yes, so with your question being about how she does not have typical hypsarrhythmia, which we certainly see more and more,
No, but in your second patient on the video, I didn't see the typical hypsarrhythmia.
Correct. Yes, I agree with you. I agree with you that we're seeing a lot of patients who don't meet that classic criteria for hypsarrhythmia.
So are you based on clinical diagnosis and the EEG?
Correct, exactly. So having the classic EEG correlate to spasms, an abnormal EEG background, and the classic setup. That patient actually has tuberous sclerosis as well. And then we had seen her, believe that, yes, that was how we diagnosed her, was her spasms first. And then she had her MRI showing that she did meet criteria for tuberous sclerosis.
In patients, for example, that have a normal MRI, normal development, and suddenly start with infantile spasms, it's better to start prednisolone alone or prednisolone with vigabatrin at the same time?
Oh, yeah, great question. So, yeah, talking about normal MRI, normal development, and spasms, should we treat with prednisolone alone or prednisolone plus vigabatrin dual therapy? There had been a lot of interest for a while in doing dual therapy, especially for children who have known structural abnormalities, and that's certainly still an option. But I think most of us trend toward just starting with steroids alone and then switching to vigabatrin or adding it on if need be at that 2-week mark if there's still more. That benefit that was seen with kids doing dual therapy tended to be for kids who were already having other developmental issues too, so, and structural lesions in particular. Thank you very much. I appreciate it.
So a decade ago, and before that, at least, there was this huge controversy that raged back and forth about whether prednisolone was acceptable versus ACTH, and it was like almost like armed camps. I gather from your presentation that at least in your mind, that's been settled in favor of prednisolone now.
Thank you, Dr. Rich. It's a great question. Yes, yes. I think with the UKISS trial showing the non-inferiority of steroids so that we can use high-dose prednisolone, that was with Kossoff's group, I think that that's been pretty well answered to me anyway, that we can start with high-dose steroids and that we do not need to jump right to ACTH, especially knowing some of the limitations in accessing ACTH, parents' hesitation in utilizing it, and the cost factors that we're all trying to be mindful of, right, for healthcare costs. Thank you. Yes, Dr.
I'm just curious about the rate of spasms in NICU graduate patients. Kind of what are we doing to educate families before discharge from the NICU? Should we be doing more to prepare them so when they follow up with the pediatrician or the NICU follow-up clinic or something, there's that's kind of more in the back of people's minds that they should be looking out for that?
Yes, that's a great question. So Dr. Friedman was, again, for anybody who couldn't hear, talking about NICU graduates and how are we preparing and educating families on anticipating that they may have spasms in their course, and that might even be several months down the road, which is the scary part. So I think many of us who do see NICU consults, I'm looking at Dr. Ferrante because I'm sure she would have a thought on this as well. I'd like to tell families about that, especially when we've really struggled with getting seizures under control while in the NICU, and we know that they have a structural abnormality on the brain. That's part of the education that's happening in the NICU from our team anyway, to talk about the fact that they may develop other seizure types. And a particular one to look out for would be this, and I usually literally demonstrate the spasms and what they might look like and how that could be months down the road. Thank you.
Yeah, so somewhat similar question, and I was going to ask it the same, but with a twist. Do you think that inversely, would it help creating a video file for families leaving the NICU to say these are the potential seizure types that may occur, instead of just describing it?
Instead of me just acting it out. I love acting it out. That's usually what I'm doing.
Yeah, that's one thing. And then the second thing, more of a statement. The issue, I think, with steroids previously, we used to use 2 to 4 per kilo. But once they increased the ante and started using a higher dose, they found more equivalency, I think.
Yeah, no, definitely. No, I think that the idea of a video diary of things to show families in advance is a great idea. Sometimes scary, but also a great idea just so they're hyper aware, for sure.
So I almost want to answer.
I know you do.
So first and foremost, I can
This
say
is Dr. Ferrante, neuro NICU, a neurologist. Okay.
I can say that there's definitely room for improvement for education on infantile spasms while the patients are in the NICU. When I see these babies at 3 months, it's usually the HIE babies I give a spasms spiel to. I have a bookmarked YouTube video actually with different semiologies that I show families. And then on the Hope for HIE website, they actually have a whole page dedicated to spasms education. But I think there is room for improvement on that front from many different etiologies of brain injury in the NICU.
Yeah, no, I think that's a great point you made. Thank you. That's excellent. Thank you guys very much. Appreciate it.